Thank you, everyone, and thank you the whole panel for coming together. Early hours and late hours for Madhavi, and thank you for Victor for putting it together. Um, as all of us have been following news, and we know that India is going through a devastating second wave, and the pandemic continues to wreak havoc in India. And the daily numbers are increasing rapidly. I think the last news I read was the daily count was new confirmed cases were approximately 4,000, and the deaths also around 4,000. And situation is probably much worse, as medical experts are saying that the actual numbers of the country may be 5 to 10 times higher. So we know that things are horrible there. The health infrastructure is overburdened under the weight of all new cases. Us hospitals have been following news, have run out of oxygen, beds, crematoriums, burial grounds have run out of space for dead patients. This morning, the news was that the two big rivers in India, Ganges and Yamuna, are flooded with dead bodies because there is no place for a crematorium, and there is a shortage of vaccines. So I will not go into kind of the details about what is happening. But what I thought we'd do in the next 6-7 minutes is just contextualize the Indian case. And so I'm going to give you a very quick background and just a very quick answer to how did we get here? What went wrong? So just for a quick background, the first case, confirmed case in India was on January 30th, 2020. The first wave began to spike in early March, approximately about 23 daily cases and about 126 deaths. On March 21st, Modi government declared a lockdown. It's a it was a lockdown that then has the two renewal of lockdowns. It was considered the harshest lockdown in the world. I'm sure you heard about the migrant workers, how they were one of the more kind of victims of that particular lockdown. The lockdown lasted till May 17th. After a month or so, India opened its economy fully, completely. And then the spike kept on happening till September. And then suddenly it started going down. And so what we saw just before September, about 100,000 cases. At the end of September, it was about 11,000 cases per day. So there was a lot of speculation in India why India is seeing the reduction of virus while the whole world is going through a huge number of spike in numbers and what's happening. So there were all sorts of speculations happening, the herd immunity, India's younger population, but everybody seemed to be kind of speculating and confused about why it was happening. But the Modi government began to congratulate itself in just saying that its proactive lockdown had worked from March to May, and declared at that time, after September, October, November, began to declare that India was moving in the direction of a complete triumph over COVID. In January 2021, this year, Modi began the vaccine diplomacy, distributing about 66 million doses to 91 countries. Modi declared that India had won over its battle, and now it is India's turn to help the world around. But in February 2021, there was an abrupt and dramatic change. So as the number of daily confirmed cases and deaths began to appear. So second wave actually begins in major cities, Delhi and Mumbai, then moved on to two other major cities, and then from there to other urban areas, smaller cities, and to the rural communities. And rural India, you should know, and is 70% of India's population. So that's just a kind of a brief kind of summary for you where we are now. So how did we get here? The obvious and apparently simple answer, I would say, is which almost all of us are saying, is complacency on the part of the Indian government and the citizenry in general. by which, because of that, you have why the complacency, and what did the complacency lead to? The complacency is because of the complacency, we found the government did not have a plan, any political plan for the second wave. It was just unprepared. It got involved, for example, in vaccine diplomacy when it did not have its own supply of vaccine. It actually puts its first order of vaccine on January 3rd, 2021, while other North American countries and European countries had secured their supplies much earlier. It allowed festivals, elections, public gatherings, which were the huge super spreader of the virus. So, but those are kind of the obvious answers, which we find, for example, all written in newspapers also. But I think if you scratch the surface and actually look below this complacency, we find the more accurate explanation is Modi's populism. And that populism and the populist government is India's particular brand of populism, which is Modi's strong personalized politics, along with majoritarian nationalism, which is basically building a new India and Hindu India. So add to that the personalized politics, populist politics of Modi, majoritarian nationalism. Add to that mix is Modi's populist government's deregulatory and neoliberal market agenda. So let me just go through quickly what are the implications of this Indian brand of populism in 4 different ways. So one of the implications, or one of the consequences of this, has been that there's been politics over science. And Modi government has ignored scientific opinions. Even his own scientists, the appointed scientists, for example, a group which his government appointed this beginning of January to look at the different variants, they warned Modi government that there is a new variants are coming, and there will be this virus is going to spread very, very quickly. So Modi government has completely ignored, and politics has been fundamentally taking the precedence over science. The second consequence is the punitive populism. Punitive populism is about silencing critics of government's policy and lack of policy. And any kind of criticism has been viewed that criticism fuels negativity and creates fears and mistrust. So therefore, no criticism is to be allowed. Third, there's a huge effort on the part of Modi government's agenda in terms of rebuilding India, creating a Hindu India. So therefore, capturing power in states where there have been opposition parties in power. So have as many states, have BJP government in power as many states as possible. And so therefore, electoral campaigning took precedence over public health. And finally is push for market agenda for vaccinations. We have in India a very differential and multiple pricing strategy for vaccine. So public good has become a market commodity in India. So the answer to the question, what went wrong? I think from my personal point of view, we are witnessing lethal populism in India with these disastrous consequences. And so that's the context which I'm going to leave with you. And if you want to know more about it during question and answers, we can work through that. So going to go to our panelists. Very thankful to have Kaustuv with us from Delhi, waking up at 5:30 in the morning. And so he's going to speak about the situation on the ground, what is happening there, and what are the civil society's responses to the gaps which the Indian state has left.
Thank you, Reeta. Thank you, everybody. Thank you, Victor, for having me. I have a short presentation, which I would like to put up now.
John, are you able to allow sharing? Great.
Is this visible? Perfect.
Yeah, you might want to just put it up. There you go. Perfect.
Yeah, perfect. Thank you, John. I'm going to start from the second wave itself. Thanks, Rita, for giving the background on how we ended up in the second wave. So as of the 8th of May, Saturday, we recorded 4 lakh new COVID-19 cases. That means 400,000. And taking the death toll, taking the total caseload to about 2.18 crores, which is about 20 million. Out of these, 3 million cases are currently active, and while 1.79 crore, which translates roughly to about 18 million people who have recovered. Now, as on 8th May, there were 4,187 deaths reported. These are the official figures, and the total death toll now stands at around anything between 240,000 upwards of that. At least 14 cases are reporting active cases in 5 figures. Maharashtra, about 54,000. Karnataka is seeing a major surge at this point of about 49 to 50,000. Kerala has about 38,000 cases. Amid India's second wave, 24 states have reported a test positivity rate of more than 15%, and 9 states have reported a positivity rate of 5 to 15% last week, according to government sources. According to the Health Ministry, at least 30 districts have showed a steep upward trend in the last 2 weeks. Maharashtra, Uttar Pradesh, Delhi, Rajasthan, Gujarat, Madhya Pradesh, and Chhattisgarh are the states where there is some sort of plateauing right now. Hopefully that will remain, and that will not spike from here. However, Karnataka, Kerala, West Bengal, Tamil Nadu, and Odisha, these are the states not in North India, are showing an upward trend in the last week or so. It also needs to be known that Kerala, West Bengal, Tamil Nadu very recently had elections for the local assemblies, like Rita mentioned in her opening speech. To put this into global perspective, according to WHO, India accounted for 90% of cases and death in South Asia, and 46% of global cases and 25% of death reported last week. According to the experts and the principal scientific advisor to the Prime Minister, last Thursday, he said the third COVID wave is inevitable. According to experts, there has been, moving on to the next slide, it is seen that the second wave is moving far more rapidly than the first wave. As the graph shows, the second wave has a far steeper rise in a matter of 3 months, whereas when you compare that with the first wave. A doctor in Kerala State COVID task force mentioned that this rise was not unforeseen. There were warnings. There were data shared with the administration that the second wave would be lethal, and India let its guard down when the daily infections in January fell below 20,000 from a peak of 90,000 in September 2020. Some of the reasons for that: big religious gatherings, a reopening of most public places, and extremely crowded election rallies were being held in India. Modeling suggested falsely that India had reached herd immunity, but sero survey by ICMR, Indian Council for Medical Research, in January suggested that only 21% of the Indian population had antibodies for COVID-19. In short, jingoism, overconfidence, and false reassurance from political elites negated the hard-won progress that India made during the first wave. And hence, we are here at this point where India is literally gasping for breath. Here are some on-ground situations at this point. There is several cities in India just have a few dozen ICU beds, and they are right now frantically trying to build new infrastructure. These are being done. These are being done in a makeshift arrangement manner in hotels, stadiums, places of religious gatherings, etc. So as you see on the chart above, on the screen, sorry, the dedicated COVID facilities are 15,000 odd. Isolation beds are about 1,500,000. ICU and oxygen supported beds are also put up there. If you see the graphs to the right, courtesy of BBC, most of these are occupied or almost nearly completely occupied in the major cities like Mumbai, Delhi, and Ahmedabad. These are the cities which have initially shown the highest spike in the cases. According to the Union Health Minister, Economic Times 2020, I quote, as of 2020 December, there were about 15,359 facilities across the country. In total, about 15 million isolation beds and 270,000 oxygen supported beds. And the numbers might vary to about 1% here and there, but these were the numbers at the end of December. There are disturbing reports of people trying to find beds and not getting time, not finding them and dying from not getting timely treatment. It needs to be understood why this is the case. Between 2009 and 2019, India invested less than 2% of its GDP in public health. This percentage has continued to drop, with barely 1.1% of the GDP going towards public health last year. This is according to PRS, Parliamentary Research Committee's data. Overall, the health budget has increased from about 67 million to rupees, to about million rupees to about 73 million rupees. While this is an increase of about 10%, the allocation for this year is in fact less than the revised estimates for 2020-2021, which was about 85 million. So in fact, the plan is to spend even less than what it was being spent in the last year, 2020. So there's moving on from this. Hence, we see the next problem, which is oxygen shortage. Supply shortage of oxygen has seen has been making the headlines all over Indian media. As you see on your screen, there are news clippings where 12 or more people have died in the Batra hospital, which is right a stone's throw from where I stay. A neighbor of mine passed away in the same hospital on the same day. Yes, there are disturbing signs put up on the gates of these hospitals where they are saying that we cannot take in further patients. Hospitals have resorted to putting out SOS messages, as you see on the bottom of your screen. This is one particular example from Max Smart Hospital, in one of the leading private hospitals in New Delhi. They are putting out SOS messages for urgent supply of oxygen. Amongst the states which are the worst affected, Maharashtra and Gujarat in the west, Haryana and Delhi in the north, Madhya Pradesh in central India. In the northern states of Uttar Pradesh, some hospitals are completely out of oxygen, and they are kind of sending patients back home. 7 months ago, the country had the similar crisis, but this time it's worse. Typically, healthcare facilities consume about 15% of oxygen supply. The rest is consumed for industrial use. But amidst the second wave, 90% of the country's oxygen supply, which is about 7,500 metric tons daily, is being diverted or being used for medical purposes. This is 3 times as higher than the first wave. To put it into perspective, the Federal Health Ministry had invited bids for new oxygen plants in October 2020, more than 8 months after the pandemic had started in India. Of the 162 that were sanctioned, only 33 were installed so far. 59 will be installed probably by May, and till then, it's left the general populace to run from pillar to post to procure oxygen cylinders. That has kind of given a ripe environment for black marketing of supplies. States facing such shortages have seen prices of these oxygen cylinders, concentrators, life-saving drugs just skyrocket. The prices of them have just skyrocketed. Families who are trying to put together home treatment facilities for their loved ones are finding it very difficult, because all of this has meant that the public health care system has failed, and this has been privatized. So people are scrambling and cobbling to make ends meet and procure these resources. Now, moving on to slow vaccination. India administered about 16.49 crore doses, which is about 16 million doses of COVID vaccines so far. And the doses of vaccines that we have in India requires each person to have 2 doses. So that would mean that is enough to vaccinate 6.1% of our country's population. During the last week, India averaged about 1,900,000 odd doses each day. At this rate, it will take about 142 days additional to vaccinate 10% of our population. This is according to the Reuters. The message that the COVID-19 was essentially over, and multiple sentiments of victory over COVID was echoed by people in the federal government as well as the state governments. The Prime Minister in multiple speeches, the Health Minister in multiple speeches had echoed this feeling, has kind of led to a slowed start to the vaccination process. There were also a lack of coordination between the federal level government and the state level governments. The government at the federal level shifted the focus of it. Initially opened up to population above 60, then it was opened up to population above 45, and then suddenly the central government thought of expanding the vaccination to everyone older than 18 years. This meant draining supplies, creating mass confusion, and a market for vaccine doses in which states and hospital systems competed against each other from 1 or 2 suppliers of oxygen in India. Sorry, I also want to quickly point out to the fact that if you look at the spike, the graph on 13th April, there's a from 13th April, the vaccination curve kind of dips, and meanwhile the COVID infection rate continues to climb. Underreporting of deaths. Yes, very sadly, there are images of bodies of COVID deceased patients floating in the river Ganges, Yamuna, and there are reports coming in from Uttar Pradesh that they've floated down till Bihar. According to University of Washington's data, India's actual death toll could be thrice to be on a conservative side. The official reported figure is about 200,000 odd at this point. This has led to crematoriums and cemeteries being overwhelmed. Some of the images are very disturbing, and so I want to point out right away. These are funeral pyres. The photograph on the top shows funeral pyres being lit in a makeshift parking lot right next to a densely populated neighborhood in Sarai Kale Khan. Sarai Kale Khan, urban slum, where, for instance, the cremation site gets 60 to 70 bodies. Sorry, on a regular day, the cremation site gets about 20 bodies a day, is now accounting for 60 to 70 every day. They have created 100 new platforms in raised green, in the green spaces, open spaces next to them. People have utilized empty parking lots. Other 25 crematoriums are so overrun that the municipality is recruiting new civic workers to kind of keep these running. The land crunch, apart from the land crunch, we see that wood, which is required for the cremation, is running out. Some reports state that a caretaker at Geeta Colony's crematorium said that they had stock up to 2 months of wood, which got over in 10 days. So that kind of gives you an idea of how many, the kind of pressure the system is under. The similar cases for cemeteries in India as New Delhi as well. And the Kabristan mentioned on the slide is completely overwhelmed.
Gustav,
migrant
if you don't mind, if we can wrap it up so that we can move to
Sure.
the other speakers. Thank you.
A couple of more minutes, please. Then I'll quickly finish. The migrant workers have again borne the brunt of loss of livelihood and the unbridled situation where the Delhi government has been announcing lockdowns on a weekly basis have left them in a limbo. So they've either gone back because they have to provide for their families and not pay rent here while they are not earning anything in Delhi. So how has the civil society responded? Civil society response has come at two levels. One is in form of citizen action. In citizen action, the youth, especially the youth, has come to the fore. They have used social media to a degree where they have compiled, shared, verified data on the availability of medical supplies, hospital beds, and they have done that very, very effectively. They have also called out black marketeers and ambulances who have tried to fleece people of money while providing the services. Instagram particularly has become the unofficial disaster management agency of India at this point, a dashboard. Startup campaigns have funded crowdfunding to procure medical help, medical supplies. Some of the examples are of these aggregator platforms through which we get our food delivered in India. Faith-based agencies are not far behind as well. Gurudwaras, which are Sikh temples, they have started oxygen langars, where they have drive-in facilities for patients who can come and avail of the free oxygen facility till their loved ones find a place for them in hospitals. A mosque in Jahangirpura, which is in Vadodara, has been made completely converted into a makeshift hospital. And there are umpteen stories of such coming to the fore at this point. What are the NGOs and CSOs doing? They are primarily categorized in three aspects, three blocks. Relief action, where these NGOs are providing food, medical supplies. They're supporting migrant workers in terms of providing them digital literacy, connecting them digitally through to payment platforms. Then, of course, awareness generation, and where they are also at the forefront of disseminating verified messages. They are getting doctors and on certain panel discussions, having these doctors to share about what to do and what not amidst the pandemic, from the perspective of health and hygiene. Also, they are providing mental health support to the families of the patients and the deceased. Last slide. The structural challenges which prevail are NGOs say that the NGOs and private foundations are facing with the impediment of FCRA, Foreign Contributions Regulation Act, which prohibits anyone to receive any foreign cash aid in donation from cash and other sources without an FCRA license. This is very difficult, given the point that right now everybody's trying to rally together support from all across the world, and there is an instance of a private donor trying to facilitate a building of an oxygen plant in one of the leading hospitals in Delhi, but that is under process because FCRA regulations don't permit that at this point. Although the government had opened up no GST imports of these equipments and supplies, but the government did not clearly specify anything under the FCRA. So what
Can we
needs to
come
be
back,
done?
Kaustuv, can we come back to this
Sure,
one
sure.
at the question and answer period?
Yes,
so that we
I'm so sorry to overrun.
No problem. Don't worry about it. But we'll come back to it. Okay. Thank you,
so much.
Kaustuv. So I'm not going to take too much time. We're going to shift from now a little bit focus and just talk about the global impact of the Indian crisis. So I'm going to pass it on to you, Madhavi, with regard to intellectual property rights and a virus and vaccines and etc.
Sure. So I'm a professor of IP law, and I'm going to be talking about the World Trade Organization waiver, a proposed waiver to suspend IP rights in COVID-19 therapeutics and vaccines. It's been in the news quite a bit in the past week, so I'm going to give you a little bit more details about this. But I want to take us back briefly, because 2 decades ago, in the midst of the AIDS crisis, the WTO issued a declaration affirming at that time that intellectual property rules, quote, should not prevent members from taking measures to protect public health, unquote. But the clarification of the right of nations to issue compulsory licenses on essential medicines came too late at that time. By then, more than 5 million people in low and middle income countries had died from AIDS, waiting for the WTO to clarify its rules. And now we're in the midst of a pandemic that has cost over 3 million lives worldwide to date, and the WTO delays again. Last October, India and South Africa proposed a temporary waiver of IP rights to issue compulsory licenses under current WTO law. But the problem is that those rules are very cumbersome and they can take years to finalize. So the waiver proposed suspending these IP rights for the duration of the pandemic to ramp up vaccine production and to end the pandemic before the spread of deadlier global variants. But the US and Europe opposed the waiver last October, and they thereby prevented the World Trade Body from obtaining the consensus that's required. Despite over 100 low and middle income countries supporting the waiver. The WTO punted again last December and again this past March. In the meantime, India spiraled into catastrophe as deadly fast spreading variants took hold before the nation could produce and administer sufficient vaccines. So whether the humanitarian disaster in India is the result of the WTO delay will be debated for years. What is clear is that the crisis in India, which is also the largest producer of vaccines for low and middle income countries, spurred without a doubt the Biden administration to change its own stance on the waiver last week. Dr. Fauci, world leaders, Nobel laureates, and now the Pope too, have all publicly supported waiving IP rights to help scale up production of vaccines to end the pandemic. Even Bill Gates, who had staunchly opposed waiving IP rights last week, reversed course and announced support for the waiver. Despite this growing support, however, because the WTO makes decisions by consensus, and we still have many European countries opposing the waiver, a deal could take weeks, if not months. Some say perhaps 8 months. I want to submit, though, that even if an official waiver is a long way off or may never even happen, the change in the US position is significant. So first, the waiver has brought global attention to what is being called vaccine apartheid. Compared to 2 months ago when the WTO met and rejected the waiver, today the world is finally watching and the inequity is glaring. While in the US, where we heard today that kids ages 12 and up will be eligible for vaccines now, beginning this week. To date, only 0.3% of jabs have been administered in low-income countries. Second, the threat of a waiver will indeed force companies to the bargaining table sooner rather than later. And in fact, Moderna pledged last Monday its first ever commitment to manufacture vaccines for low and middle-income countries, committing to make an additional 500 million vaccines by late 2022. And later in the same week, last week, Pfizer-BioNTech pledged to manufacture 2.7 billion vaccines in 2021, with 40% of these targeted to low and middle income countries. So within a week, there were additional pledges of up to 1 billion more vaccines in the shadow of a looming waiver. So now critics, however, argue that the waiver itself, if it's to come, is unlikely to expand vaccine access. And they cite limited supply of raw materials, limited manufacturing capacity, and challenges with distribution on the ground. And to be sure, there are indeed a number of challenges that lie ahead. It will take a holistic governance approach to overcome these numerous challenges. But the Biden administration has already made commitments to improve access to raw materials using Defense Production Act and lifting embargoes, for example. And advocates in the meantime are calling on the US to take a more holistic governance role in approaching this problem. But I want to talk about the role of patents, because make no mistake, patents themselves are relevant and they do play a critical role in the current public inequity in vaccine access. So patents lead to limited supply of vaccines. Patent owners and their licensees are the only authorized producers. Thus, the Serum Institute of India, licensed by Oxford University and AstraZeneca, was one of the only authorized producers of vaccines for low and middle income countries, a goal they've been unable to meet given the Indian government mandating now that doses be directed to the domestic population first. Second, companies are primarily incentivized to produce drugs for populations that can pay. So this is why we have numerous new drugs to treat erectile dysfunction and baldness, but not malaria and tuberculosis, which are, alas, diseases of the poor. Similarly, vaccine companies have authorized production of doses to those parts of the world that can pay. These companies have little incentive to prioritize doses for the poor. And this is why it was just until last week that Moderna had only pledged to make 700 million to 1 billion vaccines this year in 2021, and had not pledged to contribute at all to the philanthropic effort COVAX, which seeks to procure and deliver doses for lower income countries. So the bottom line is that market incentives alone will not meet the vaccine needs of the world, much of which cannot afford to pay. So this is why we need government solutions to achieve global vaccine equity. Vaccine equity is, of course, a moral imperative. And what we've heard from Kaustuv is heartbreaking and so disturbing. Vaccine equity is also necessary for US national security, for every country's national security and public health. As the World Health Organization has put it, no one is safe until everyone is safe. So I want to just dive in here a little bit to just also emphasize that whether we ultimately see this waiver or not in either a narrow or broader form in the weeks or months ahead, it's critical to recognize that the waiver is just a first step. Perhaps even more critical is for manufacturers to make safe and effective vaccines, in order for manufacturers to make safe and effective vaccines, they need more than the patent or the recipe. Companies have to share their know-how and help build capacity so global manufacturers can stand on their own 2 feet in Africa and beyond to make safe and effective vaccines for this pandemic and to be prepared for the next one. So experts say that collaborating with the World Health Organization, public health experts, and generic manufacturers in Africa, Asia, and Latin America, that this kind of collaboration could help us to set up multiple sites for manufacturing, and within months, with an investment of just a fraction of what we're paying to donate vaccines, factories could be retrofitted to produce millions of doses of high quality vaccines. But of course, drug companies resist vehemently a waiver or any suggestion of sharing, forced sharing of their technologies. And their number one argument is that this would negatively harm incentives for future innovation. But we absolutely need to probe the mantra of incentives. In fact, many of these technologies were paid for by taxpayers. In the case of the Moderna vaccine, the US government paid 99.9% of its costs. Moderna also relies heavily on a patent owned by the US government, as it was researchers at the National Institutes of Health that developed the basic spike protein research underlying Moderna's vaccine. So this taxpayer-funded technology should be treated as public goods. Furthermore, patents have never been considered an end in themselves. They're tools to promote human flourishing, and this has always been the case. A century ago, the US government broke the Wright brothers patent in flight technology because the know-how there was critical to the nation's effort in World War I. And this pandemic presents a similar extraordinary national emergency, recognizing again that we are not safe until everyone around the world is safe. The waiver, along with technology transfer, is critical to scaling up vaccine production quickly, faster than donations alone can do. I'll just say a couple words about India in particular, and that is that the UN Secretary General, Antonio Guterres, has hailed India's vaccine production capacity as, quote, one of the best assets the world has today. India, however, didn't get here without incredible forethought and a particular view of patents as tools to promote the widest possible access to the benefits of science and to promote India's own indigenous industry. And I'm not going to have time here to go into the details, but India's patent law is itself a model law that we need to be looking to. India, called the pharmacy to the developing world, has been there for the world, providing safe, effective, and accessible generic drugs for decades. And we need to be there for India now. Going forward, we will continue to rely heavily on Indian drug manufacturers, which with a waiver can produce vaccines for India and other low and middle income countries. The last word I'll say is on tech transfer. Tech transfer was actually at the very heart of the bargain underlying the agreement on trade-related aspects of intellectual property at the formation of the WTO in 1995. And in fact, the agreement was controversial from the start. It was decried as colonial policy, but the only thing giving it legitimacy was the promise of technology transfer to low and middle income countries. If wealthy countries turn their backs on that promise now during a crippling global pandemic, the entire international IP infrastructure is going to be exposed. I'll leave it at that because we want to get to Professor Lin, so look forward to conversation if we have time after.
Thank you very much, Madhavi. So Vivian, I won't say much, but you'll talk about global public health and implications and learning lessons from India.
Thank you so much. We've heard from Reeta and Kaustuv a humanitarian catastrophe in the making. And Madhavi talked about part of the solution around vaccines, But as we have seen in all countries through the pandemic, health is a lens through to so many other issues in society and economy. And everyone in the world is impacted, especially by the large countries, such as India. Could this have been predictable? Probably. There were other variants with higher transmissibility before we saw what was happening in India. In every single country with multiple waves, every successive wave has been bigger and longer than the previous one. So we've not been really good at learning the lessons from each other. And I think this is something that we need to do. Now, in the course of this pandemic, the one area where there's been extraordinary collaboration and very rapid progress has been in the biomedical and the scientific research side. And in one respect, if you have to find a positive aspect to anything, you'd say, okay, the India epidemic is teaching us a lot more about variants and whether vaccines are effective and what might be the next generation of vaccines that we need to be working on. But that's a very small silver lining in this very dark cloud. So let me talk a little bit about some of the global and local epidemiological implications and the lessons for other countries and what I think maybe are the areas that require attention next. As this pandemic has gone on, we've seen more variants. And the longer it goes, the more variants we will get. The more variants we get, the longer the pandemic goes on. So, and this is just because viruses are very clever. This is how they survive. This is, biology. So this really speaks to the great importance of global solidarity in actually trying to manage it and manage it quickly. Because as we have also seen as the pandemic has unfolded, the question of vaccine effectiveness has come up. The longer we go and the more variants that occur. So we're looking at the current situation as a very, very serious public health challenge. But I think India's significance possibly goes beyond other countries with the very high rates. Because of the way India, the population, the economy is linked to global patterns of trade, of migration, the diaspora. And so everything that happens in India affects many more parts of the world compared with, say, Brazil, which is not an insignificant country in itself. So I think India at a global level is of particular concern on the scale that China would be of concern. And of course, as we pay our attention to the very desperate needs in India, we also realize that takes away the attention and the resources from other places that need it. So we really have this very challenging situation globally about how do we manage the limited supply of vaccines, of oxygen, of drugs for treatment purposes. So there's a whole set of issues about the COVID situation in other low-income countries in particular, and whether there's not going to be enough supply for them. But what we also see in India, as well as other countries, that when countries decide that they have to put all their resources into COVID, other health problems do not get the kind of attention, whether that's cancer treatment, blood pressure and diabetes medicines, antenatal checkups and postnatal care, HIV treatment, tuberculosis drugs, immunization. So we see particularly the preventive health services go into decline. So when we think about excess mortality, there's the excess mortality related to COVID, which may or may not be reported. Then there's other mortality, which relate to the fact that the healthcare resources are no longer dealing with all those other pre-existing health issues. And of course, there are other epidemics going on in the world which are not getting its attention. Congo has just finished its 12th Ebola epidemic. And do we hear about it in the world? No, not very much, unless we're paying attention to it. Are there resources that go into it? Yes, there are people who have gotten resources there, but these are the kind of consequences when we have a major outbreak, such as India. And of course, when we see the kind of pandemic that happens, we're also seeing that this actually contributes to the Asian hate that is happening in so many parts of the world. And we have to recognize that also as a public health issue because of the obvious mental health consequences, let alone any kind of physical health issue. So the kind of discrimination and stigma that happens within a country becomes much more extended globally. So I think these are the kind of some of the more immediate health type of concerns that we have. And if we take some of the issues that both Reeta and Kaustuv have talked about, there's several things that countries really have to pay attention to. And I wish we could actually develop an approach where we all learn better. The first is that the public health functions and services are absolutely core to universal health coverage. And it's very easy for countries not to invest in prevention because it's not visible. But at some point, we need a surge capacity. We need to stockpile. We actually need labs that can do the tests, a workforce that can perform the tests. We need a good surveillance system and a workforce that actually understand the data and know what to do with the data. And we need, a workforce of health educators to actually work with the community and promote the kind of preventive behavior that's necessary. But that public health function has to be nested within universal health coverage. Now, India has, of course, promoted what it's been trying to do by the way of health financing in recent years. Indeed, at one point, it was being talked about as the biggest UHC effort in the world. But financing isn't enough. It's also about quality of services and equitable access for the different kinds of people in the community, and making sure that the services can reach the people who are hard to reach and the people for whatever reasons may not seek care and feel that the services may not be culturally or linguistically acceptable. So these are really important part of building a health system that is foundational to being able to manage a pandemic. But I think at the end of the day, the lesson that we have to take away is also about health governance. And health governance is particularly challenging in a federalist system, because you've actually got to connect not only the different ministries that look at health, economy, environment, social welfare, education, etc., but you've actually got to connect them at the different levels of the system. And so to do that in systems which may be highly political and subject to multiple electoral cycles, putting science at the center is really critical. And that means a network of public health and other scientists who can actually get on the same page. They will have their debates about the technical issues, but they have to actually come together to also advise government and the community about what are the reasonable measures and what are the kind of risks. And at the end of the day, it's that commitment to social mobilization and health information and literacy that is culturally appropriate for the whole of society involving social institutions that will ultimately make a difference. You know, in many ways, I would say there have been many lessons from the HIV epidemic. It doesn't matter what the disease is. The principles are similar in the way that we have to work. So I think these are some of the lessons. Looking to the future, obviously global citizenship is something we really have to work on. And that global citizen, I mean, we've heard often, you know, you protect yourself and you protect others at the same time, whether it's no one is safe until everyone's safe or viruses know no borders. These are all facts of the matter. And that means neither vaccine nationalism nor vaccine diplomacy is particularly helpful. It's about kind of managing the need within a global context. And beyond vaccines, there's, you know, any number of other supply issues and medicines issues that need to be thought about similarly and from an ethical perspective. I think there's a lot more we can also think about in terms of regional surge capacity and how we can work across borders in times of need. And whether that's through regional bodies, SAARC, ASEAN, African Union, what have you, or multilateral and other organizations, or professional bodies, the way in which the health workforce can actually be backing each other up, no different from any other kind of natural disasters that we have, the way in which the epidemiological field epidemiology expertise could be shared, the way telemedicine can actually support people. So I think there's a lot more of those kind of support that we can be much more conscious about. But most importantly, at the end of the day, is prevention. This is not going to be the last pandemic. It may be the one that has wakened everybody up to prepare. So on the really upstream side, we need to be thinking about One Health. It's the human-animal interface that's important. It's the way that we humans have really destroyed our ecosystem that is causing the emerging diseases. It's the way we've changed the climate of the planet that is creating a wider spread of various pathogens. So we've got to really think upstream about this, but we also have to think about how do we rebuild society and economy so that it's not once again the most disadvantaged, the most economically insecure people who bear the brunt. Because while we want to build universal health coverage and we want to make sure everybody has vaccines, isn't it so much better when people don't have to use it? And so here I think we have a really, really important role of all the different sectors and the communities coming together, global citizens, and not forgetting that when we say building back better, we're not talking about just the economy of one country, we're talking about us as global citizens. So thank you very much.